Hello, this is Farhad Tafezi from Zurich, Switzerland. I love performing cross-linking, and as you may know, cross-linking for keratoconus is, after 15 years of clinical application, an established technique, and we rather talk about details of refining the method. Something we are much more excited about in the past 3 years is a new indication for cross-linking, which is infectious keratitis. We call the new method Pack-Cxl, which stands for photoactivated chromophore for keratitis. And cross-linking seems to be extremely effective in killing various pathogens like bacteria, but also fungi. And if you look at the incidences of keratoconus and infectious keratitis, you will understand our enthusiasm. Infectious keratitis is a global threat to vision, is one of the leading causes of blindness. And if we talk about countries like India, we speak about several millions of new cases every year. So cross-linking might have a new field that is much bigger than keratoconus as a rare disease can ever be. The proofs of principle have been given in a series of papers, in a series of laboratory experiments and phase 1 clinical trials. And we are now setting up a large prospective multi-center trial involving 16 sites in 14 countries spread over 4 continents to show the effect of Pack-Cxl as a first-line treatment in early corneal infiltrates and small ulcers up to a diameter of 2 millimeters. And the preliminary data from the first patients are very, very encouraging, because we seem to be able to eradicate bacteria but also fungi in very early infection without using a single drop of antibiotics or antifungal medication. So the trial will run and probably take another 12 to 15 months to complete, but we are confident to look at the results latest by the next ESCRS, which will be held in Barcelona in September 2015. The proof of principle, as I said, has been given. We are able now to kill 98 to 99% of bacteria like multi-resistant Staph aureus in as little as 2.5 minutes. So our dream, of course, would someday to see this technique taken out of the operating theater into the consultation, into the practice of the common ophthalmologist, and treat the disease as early as we can in the stage of corneal infiltrate or early ulcer, and arrest the disease at a very early level. It could be less time consuming, much more efficient, less expensive as a treatment of first line than anything we have right now in the field. And our dream is to get this out to the ophthalmologist, to the area of greatest need, which would be developing countries and remote areas.